Hi, my name is Smithy Nag, and today we're going to be discussing a few clinical cases. Case number 1. You're working on a medication reconciliation consult for TJ, a 68-year-old man admitted to the hospital. The patient's past medical history includes CAD, hyperlipidemia, CKD stage 5, and depression. During interview, the patient reports taking Sevamir 1,600 milligrams 3 times daily with meals, metoprolol XL 25 milligrams twice daily, lisinopril 20 milligrams daily, sertraline 25 milligrams daily, aspirin 81 milligrams daily, and atorvastatin 80 milligrams daily. He also shares with you that he recently started ibuprofen 600 milligrams 3 times daily for osteoarthritis of the knee. What recommendations can be made to optimize the patient's knee pain management? According to the American Society of Nephrology, patients with stage 4 and 5 CKD are at a particularly increased risk of complications from NSAIDs because these patients may have diminished renal reserve and decreased ability to recover from a nephrotoxic event. For these reasons, avoiding the use of oral NSAIDs for pain management secondary to osteoarthritis is preferred. According to the 2019 American College of Rheumatology and Arthritis Foundation guideline for the management of osteoarthritis of the hand, hip, and knee, there are several non-pharmacologic and pharmacologic alternatives for NSAID use for pain management. Depending on the patient's level of fitness, exercise, weight loss, and Tai Chi are all recommended for knee OA. The literature also supports cognitive behavioral therapy for long-term management of chronic pain conditions. The guideline also recommends the use of a cane and/or knee braces for patients with knee OA. Pharmacologic alternatives to NSAIDs for knee OA endorsed by the guideline include acetaminophen, topical NSAIDs such as diclofenac gel, and intra-articular glucocorticoid injections, which have demonstrated short-term efficacy. Second-line options include duloxetine and tramadol. At this time, I would recommend discussing non-pharmacologic strategies with the patient, recommend that they discontinue ibuprofen, and initiate acetaminophen 325 to 650 milligrams every 4 to 6 hours as needed, and diclofenac 1% gel 4 grams applied to the affected knees up to 4 times daily. Case number 2. A 78-year-old man presents to the ED complaining of black, tarry stools and generalized fatigue. He was recently diagnosed with arterial fibrillation and is also undergoing treatment for lung cancer. His medical history includes diabetes, hypertension, and bilateral knee replacements 10 years prior. His medications include metformin 500 milligrams by mouth twice daily, lisinopril 20 milligrams by mouth daily, warfarin 10 milligrams by mouth daily, and a multivitamin by mouth daily. The patient has normal labs except for an INR of 12 and a low hematocrit and hemoglobin. His workup reveals a GI bleed, and the provider has asked you what he can use to reverse the warfarin. What is your response to the provider? According to the 2020 American College of Cardiology Expert Consensus Decision Pathway on Management of Bleeding in Patients on Oral Anticoagulants, options for reversal of vitamin K antagonists such as warfarin include vitamin K, prothrombin complex concentrate, and plasma. Slow intravenous administration of vitamin K in 25 to 50 milliliters of normal saline over 15 to 30 minutes is preferred for predictable and rapid reduction in INR within approximately 4 to 6 hours. However, the results of vitamin K are not immediate, and given that this patient has an INR of 12 and a GI bleed, administration of vitamin K must be accompanied by a repletion strategy, either with a 4-factor prothrombin complex concentrate or fresh frozen plasma. In this case, I would recommend 4-FPCC or Kcentra. Kcentra can be dosed using either weight-based dosing or fixed INR-based dosing. From my experience at St. Peter's Hospital as a student, I learned that per protocol, Kcentra is dosed using fixed INR-based dosing in patients who are on warfarin specifically. For patients who are greater than 100 kilograms or have an INR greater than 7.5, 2,000 units of Kcentra is used. Given that in this case the patient has an INR of 12 and there are no known contraindications to therapy, vitamin K administration should be accompanied by administration of Kcentra dosed at 2,000 units given intravenously through a separate line. Case number 3. DF is a 43-year-old man with heart failure and a left ventricular ejection fraction of 35%. His comorbidities include CAD, hypertension, PAD, hypothyroidism, CKD, and anxiety. His medications include aspirin 81 milligrams daily, atorvastatin 40 milligrams daily at bedtime, enalapril 10 milligrams twice daily, furosemide 40 milligrams twice daily, levothyroxine 100 micrograms daily, sertraline 100 milligrams daily, and metoprolol SR 100 100 milligrams twice daily. The patient has a weight of 74 kilograms, a serum creatinine of 1.6 milligrams per deciliter, a serum potassium level of 4.6, a blood pressure of 120/70, and a resting heart rate of 76. His heart failure is chronic, stable, and he is currently NYHA Class 2. Please address each of the following interventions, stating whether you would implement or not and the rationale for your answer. The answers to the following questions were developed based on information provided in the 2017 Guideline for the Management of Heart Failure, published by the American College of Cardiology, American Heart Association, and the Heart Failure Society of America, along with the American College of Chest Physicians. Should we transition DF from enalapril to valsartan sacubitril? According to the reference guideline, valsartan sacubitril or Entresto is indicated in patients with chronic symptomatic NYHA Class 2 or 3 heart failure who tolerate an ACE inhibitor or ARB to further reduce mortality and hospitalization. Although this patient is tolerating enalapril 10 milligrams twice daily, the patient is reported to be stable, not symptomatic. In addition, Entresto carries an increased risk of hypotension, especially in patients on a high-dose diuretic. The patient's blood pressure is currently normal but trending low at 120/70, and the patient is on furosemide 40 milligrams twice daily. Without additional information about the patient's BNP or NT-proBNP levels, along with the risk of hypotension and estimated creatinine clearance of 25 milliliters per minute determined using global RPH, I would not recommend transitioning the patient to Entresto at this time. It may be more prudent to optimize the patient's current beta blocker therapy and reassess this recommendation should the patient become symptomatic. Should we discontinue metoprolol and begin carvedilol? Metoprolol tartrate is available as immediate release and sustained release forms, whereas metoprolol succinate is available as controlled release or extended release forms. While metoprolol succinate is preferred of the two for patients diagnosed with heart failure with a reduced ejection fraction, carvedilol is another beta blocker with increased vasodilating effects through blockade of alpha-1. Given that this patient has a history of coronary artery disease and peripheral artery disease, a vasodilating beta blocker such as carvedilol may improve coronary flow reserve, peripheral vascular resistance, and ejection fraction. While studies have shown that patients on metoprolol doses of 100 milligrams or greater and a systolic blood pressure greater than 100 can be switched to a carvedilol dose of 25 milligrams, some patients did experience hypotension and bradycardia at this dose. The starting dose for carvedilol in heart failure patients is 3.125 milligrams twice daily. However, given that this patient was already on beta blocker therapy at a dose of 200 milligrams of metoprolol daily, it is recommended that the patient discontinue metoprolol and initiate carvedilol at a dose of 6.25 milligrams twice daily and up-titrate every week as tolerated to the target dose of 25 milligrams daily. Bradycardia, hypotension, and fluid retention should be monitored initially and with dose increases. Should we add ivabradine to DF's existing regimen? Ivabradine is a relatively newer agent that provides heart rate reduction and has shown benefit in reducing hospitalization for patients with symptomatic NYHA Class 2 or 3 stable chronic heart failure with an ejection fraction less than or equal to 35% who are currently receiving guideline-directed management therapy, including a beta blocker at the maximum tolerated dose, and who have a heart rate of 70 beats per minute or greater at rest. While this patient does have stable chronic heart failure with an ejection fraction of 35% and a heart rate of 76, the patient's current beta blocker therapy can be optimized as previously discussed. In addition, while ivabradine shows a decrease in hospitalization for patients with a hospital admission within the last 12 months, there is no impact on mortality. Because this recommendation has a weaker level of evidence at 2A, it is recommended that the patient's beta blocker be optimized and that the patient be stabilized on the new regimen prior to considering the adding on of ivabradine. Should we add spironolactone to DF's existing regimen? Spironolactone has been shown to decrease mortality and hospitalization and improve symptoms for patients on standard therapy with NYHA Class 2, 3, or 4 heart failure or ejection fraction less than or equal to 35% and creatinine clearance greater than 30 milliliters per minute and potassium level less than 5 MEQs per deciliter. While this patient does meet the majority of this criteria, their estimated creatinine clearance was determined to be 25 milliliters per minute using the resource global RPH. While I do not recommend adding spironolactone to the patient's current regimen, if the patient's beta blocker therapy is optimized and a more accurate creatinine clearance is obtained, this recommendation may be reassessed. And finally, should we add digoxin to decrease hospitalizations? Digoxin is considered last-line therapy for heart failure patients who are persistently symptomatic despite standard therapy to decrease hospitalizations. Moreover, more recent evidence may suggest that while digoxin may provide symptom relief, its use may actually increase mortality. Because the patient's current regimen may still be optimized and the patient is currently stable, there is no indication to initiate digoxin at this time. Case number 4. What is the maximum dose of acetaminophen for a patient with a Child-Pugh score of A? A patient with a Child-Pugh score of A is considered to have well-compensated liver disease. In other words, these patients have the least severe chronic liver disease, and the 1 to 5 year survival rate is 95%. There is ongoing controversy among clinicians regarding the implications of acetaminophen use in patients with liver disease. A study of physician recommendations by Rossi et al. Suggests that when used at low doses of 2 grams per day or less, acetaminophen is safe in cirrhosis patients. There are concerns, however, that the risks of inadvertent overdose and acute on chronic liver failure with acetaminophen use and chronic liver disease are increased in patients who are chronic alcohol users. Interestingly, no instances of acute liver failure were seen with daily doses less than 2.5 grams, and even in alcoholic patients, there were no statistically significant changes in serum ALT levels in patients who consumed 4,000 milligrams per day for 5 days. Nevertheless, most clinicians suggest that patients with liver disease or cirrhosis that is not considered decompensated do not exceed more than 2 grams of acetaminophen from all sources in a 24-hour period and limit the overall duration of use. Case number 5. A 49-year-old man weighing 135 kilograms or 298 pounds with type 2 diabetes and A1C 1 week ago of 8.2% has a medical history significant for hypertension, dyslipidemia, heart failure, and reduced ejection fraction with an ejection fraction of 40%, pancreatitis, and peptic ulcer disease. He currently takes metformin 1,000 milligrams twice daily. Considering current recommendations, what would be the best drug class to add to this patient's regimen to optimize his therapy? According to guidelines published by the American Diabetes Association in 2021, patients with established heart failure with a reduced ejection fraction of less than 45% have demonstrated proven benefit from addition of an SGLT2 inhibitor to first-line metformin therapy. SGLT2 inhibitors have also been shown to provide cardiovascular benefits as well. Because this patient has known heart failure with several risk factors for cardiovascular disease, including hypertension, dyslipidemia, and type 2 diabetes, initiation of an SGLT2 inhibitor is recommended to optimize the patient's regimen. The recommendations published by the American Association of Clinical Endocrinology also supports this course of action, citing that dapagliflozin has demonstrated potential primary prevention of heart failure, hospitalization, and efficacy in heart failure patients with reduced ejection fraction. SGLT2 inhibitors also promote weight loss, which would benefit this patient at a weight of 298 pounds. Thank you.